Next is our juvenile rheumatoid arthritis or juvenile idiopathic arthritis. It's very common in children around 16 years of age. It is polyarticular. There are three types: polyarticular, polyarticular, systemic. Polyarticular seronegative, that is RF negative, rheumatoid factor negative, and ANA positive, that has the most common association with uveitis. The severity also depends on these three things. So they can ask you various questions by telling you what it is, whether polyarticular, polyarticular, or seronegative, seropositive, ANA positive, ANA negative, like this. But these 3 points, which is very important. And systemic variety is called Still's disease. It's least common association with uveitis. So the patient presents with bilateral non-granulomatous anti-uveitis. This anti-uveitis is not associated with circumcorneal congestion, hence it's called white eye. It's white eye outside, and inside also there is a cataract. That's why it's a white eye uveitis. And associated with complicated cataract, extensive posterior synechial and band-shaped keratopathy is there. IOL insertion is generally avoided. It's one of the contraindications for IOL insertion, intraocular lens insertion, because of severe inflammatory reaction possibility. And intraocular lens implantation is one of the most common and advanced technique that we are doing now. But in this case, we cannot do that because of this inflammatory reaction. And these patients will have joint pain and severe painful condition in the body. So we give load the patient with systemic steroids, and because of that they'll have Cushing's syndrome. All those issues happens, and avascular necrosis of the femur can also happen because of the systemic steroids. So these patients, it's very sad to see the children coming again and again and having this troublesome problem. Next is Fuchs heterochromic iridocyclitis. It's a distinct entity. There is no gender or racial predilection, but in some books it gives us females are more commonly affected. It's associated with unilateral non-granulomatous anti-uveitis, diffusely distributed stellate white keratic precipitates. As you can see in this picture, the dots are stellate white. Stellates are like stars, diffusely distributed keratic precipitates. This is one key feature. Wherever you hear this term stellate white keratic precipitates, the answer is Fuchs heterochromic iridocyclitis. So absence of posterior synechiae, that is one of the characteristic feature. Spontaneous hyphemia due to rupture of a small filiform vessel seen in the angle. That is like when you enter into the anterior chamber during cataract surgery, you will have bleeding. That's what is Amsler's sign. So these 2 points, absence of posterior synechiae, Amsler's sign, are very key to Fuchs heterochromic iridocyclitis. Also that stellate white KPs, that is also an important point about Fuchs heterochromic iridocyclitis. And Fuchs heterochromic iridocyclitis, that name itself suggests that there is heterochromia. One eye will be lighter in color and the other eye will be darker in color. That's what is iris heterochromia. It can be depending on the patient. It can be lighter in color or more in color. And you can see in this left eye, the patient is having heterochromia along with cataract. That's what is Fuchs heterochromic iridocyclitis. There is this Schlossman syndrome seen in young males. A mild non-granulomatous anti-uveitis is associated with severe rise in IOP. So uveitis will be less, but the IOP will be drastically elevated. It's called, otherwise called as glaucomatous cyclotic crisis. I'll talk about this in glaucoma 2.